Floor is yours. Thank you, Mr. Chairperson, Mr. Chairman. Distinguished friends, welcome. Today, we will be talking about a topic which is being discussed heavily throughout the years. I will try to review the antidepressant mechanisms of actions. We as the Uludağ group prefer to share our own findings. My lecture will be a general lecture about the antidepressants in general. I think there's a difficulty with the animation. Please, could we intervene with a technical problem? You know that when we're talking about mechanisms of action of the antidepressant, we talk about a few neurotransmitters, some of which are more prominent. Noradrenaline, secreted from the adrenergic nerve endings, and the other serotonin, secreted by the serotonergic nerves. The animation is not working. There is a difficulty here. Can we please start from the beginning? This time the mouse is not working. Okay, there we go. Do you know that there are adrenergic and serotonergic terminals, and those people with depression, we do not. We have problems. One of them is the alpha-2 problem, and the other is the autoreceptors 5-HT1B and 1A. Those are those are problematic areas. Alpha-1 and alpha-2. We know that there's a problem between there's a problem in alpha-1, alpha-2, HT1B and 1A in the depressed patients. As a result of the problems of these receptors, noradrenaline and serotonin is decreased, and starting from the 1950s, we know that this is the problem, and the reflection of which is the depression. This is a general view. Alpha-2 autoreceptor and alpha-2 heteroreceptor, alpha-1 heteroreceptor, and 5-HT1B autoreceptor are the receptors that are defected in depression, as a result of which, within the synaptic gap, the amount of the noradrenaline and serotonin are decreased. Then we should aim to increase these noradrenaline and serotonin within the synaptic cleft. And some of our antidepressants actually realize this aim. Beyond this, in the recent years there have been discussions that this is not the problem in its entirety. 5-HT2 receptor sensitivity's increase is thought to have a role in the depression pathophysiology. We know that 5-HT2 has an inhibitory effect in 5-HT1. If there is a sensitivity of 5-HT2, then this will be causing the problem, because postsynaptic membrane 5-HT2 transporter number increase and sensitivity increases the inhibitory effect on 5-HT1, causing the problems in the second messengers, and thus the interventions come into the picture. Really, I have a difficulty with the animations. There is a problem with the animation, but I cannot really say how to solve this problem, so I'm really sorry about the problem with the animations. What then? This should be the second aim of our treatment. Pathophysiology. If the pathophysiology lies in the receptor, increase in receptor numbers and receptor sensitivity, then this second stage could be our treatment target. Some of the antidepressants we use actually realize the same thing. Are we able to do anything beyond this point? Yes, we are. We know that for the signal to reach the neurons nucleus, second messengers are very important. CREB and BDNF, and the decrease in their amounts are known to be a part of the problem in depression. We know that amounts of CREB and BDNF are related with the serotonin within the synaptic cleft and the receptor activity on the postsynaptic membrane. Neurotransmitters binding on the postsynaptic cleft membrane also play a role. Neurotrophic factors and less biological common pathway forms CREB and PDNF. And the decrease in CREB and PDNF amounts actually cause one of the problems in depression. And the third intervention mechanism could be to increase the neurotrophic factors amount, the amount of neurotrophic factors. These are the targets we can aim to treat depression. Let's ask this question: what do the antidepressants at hand, to what extent, realize these aims? In terms of depression pathophysiology, what we believe is postsynaptic 5-HT1A and alpha-1 are known to be very important. We have evidence. Noradrenaline and 5-HT2 amount, increase in the noradrenaline and 5-HT2 amount in the synaptic cleft is important in depression treatment. Therefore, we try to increase their amounts. TCAs and SSRIs, because of their mechanisms of action, realize the same. You see in the animation how they increase in noradrenaline and 5-HT within the synaptic cleft. Beyond 2 weeks, the serotonin and noradrenaline amounts increase. Postsynaptic membrane, and beyond the postsynaptic membrane, there are the biological changes, the cascade of biological changes, and we can restore the situation back to normal. But when we go on with the antidepressant treatment, the serotonin and noradrenaline amounts in the synaptic cleft cause feedback on the presynaptic receptors. They desensitize, and noradrenaline and serotonin amounts increase within the synaptic cleft, and postsynaptic binding, adequate postsynaptic binding causes the increase in sensitivity and numbers of the receptors, which result in the antidepressant activity. This is the mechanism that we trust with our antidepressants. TCAs, which are the gold standard, and SSRIs also, TCAs and SSRIs, work along these patterns. We also have to discuss the differences and the similarities between TCA and SSRI. TCAs and SSRIs inhibit the reuptake of the neurotransmitters and thus increase noradrenaline and serotonin within the synaptic cleft. what about noradrenaline's reuptake inhibitors? What are their characteristics? Noradrenaline reuptake inhibitors inhibit noradrenaline reuptake pump and thus increase neurotransmitters within the synaptic cleft. Although this seems to be a differentiating factor, let's see how it works with the animation. When we block the pump, normally the noradrenaline within the synaptic cleft increases. But the noradrenaline receptor's effect on serotonin terminal 5-HT1A, the effect of noradrenaline on 5-HT1A, serotonin is also increased within the synaptic cleft. Alpha-2 modulates the serotonin within the synaptic cleft. By desensitizing this receptor, we facilitate serotonin release and thus causing normal levels of neurotransmitter within the synaptic cleft. The direct effect of the noradrenaline also, although they look as if they work through noradrenaline normally, they also increase serotonin. Therefore, selective noradrenaline reuptake inhibitors actually are very similar to the TCAs and the SSRIs because of their indirect effect on serotonin levels. Selective serotonin reuptake inhibitors, SSRIs, what is their differentiating characteristic? They inhibit the serotonin transporter, and as all the SSRIs work after the same fashion. However, just like the noradrenaline reuptake inhibitors, nothing within the brain works on its own independent of the other systems. Serotonergic system has an effect on the GABAergic system and modulates noradrenaline. This is a very well-known fact. Even though you block the serotonin reuptake, you also have an effect on the noradrenaline. But this is not as direct as the noradrenaline reuptake inhibitors. This is a very indirect effect, delayed effect, and secondary effect. That is, when you use SSRIs and manipulate the serotonergic system, the chances of affecting the other system is not as direct as it is with the noradrenaline reuptake inhibitors. RIMA, reversible monoamine oxidase inhibitors. These are actually partial MAO inhibitors. What they do is they inhibit the MAO enzyme partially and increase noradrenaline 5-HT by inhibiting its metabolism. We only have a single RIMA agent. How it works is thus. It inhibits, and the 30% of the neurotransmitter, which is reuptake, its metabolism is inhibited, and therefore the noradrenaline and serotonin is increased within the synaptic cleft, and decreased transport turns into normal transport. Monoamine oxidase inhibitors seem to be completely different in terms of mechanisms. However, their effect is very similar to the TCAs and the SSRIs. They have different chemical structures, they have different mechanisms of action. However, because of the effect they exert on the terminal endings, in terms of transmission, all of these show similar effects. When we say what is the difference between these antidepressants, we can say that their mechanisms of actions are different, but when we look at the end effect, end result, we see that the differences are not really very big. What about the second stage, postsynaptic receptor and the intervention on the postsynaptic receptors? Presynaptic alpha 2 and 5-HT2 and 3 receptors seem to be the effect of these atypicals. They do not cause reuptake inhibition. Is it any different than the others? It normalizes the receptors which are increased in number and sensitivity through antagonization. Alpha-2 antagonization and 5-HT2 antagonization cause different results. What about 5-HT2 antagonism? 5-HT2 antagonism, the numbers are increased, sensitivity is increased. When you antagonize them, you decrease its effect, and its inhibitory effect in 5-HT1A is decreased. 5-HT1A activation is very important in terms of depression pathophysiology. Therefore, such a mechanism is expected to have an antidepressant activity. But these drugs do not only antagonize 5-HT2, these also antagonize presynaptic alpha-2, especially with mirtazapine and trazodone. When they exert their effects on the alpha-2 receptors, the noradrenaline released into the synaptic cleft increases. Noradrenaline amounts within the synaptic cleft, when it is increased, its secondary results are very similar to the TCAs mentioned before. In rational terms, it seems that its mechanism of action is purely postsynaptic. However, there are presynaptic contributions, and these presynaptic contributions, how much it contributes into normal transmission and how much it can be compared into TCAs and the SSRIs, the data cannot be said to be satisfactory. 5-HT2 antagonists have postsynaptic antagonism and presynaptic effects, and through their effects, they increase the serotonin and noradrenaline within the synaptic cleft, and they correct the pathology believed to be present on the postsynaptic membrane. Yes, their mechanism of action is different, but however, the end result seems to be the same. At this point, I would like to discuss something. For many years, the differences of mechanism of action have caused us to choose different antidepressants over different antidepressants. For example, we say anxiety is related with serotonin hyperactivation, therefore in anxiety treatment let's use SSRIs primarily. Or we say in anxiety 5-HT antagonism contributes, 5-HT2 antagonism contributes to the treatment of anxiety. Therefore, with depression occurring with anxiety, 5-HT2 antagonists might be used, we have said in the past years. Or remission capability of certain antidepressants in severe depression can be chosen. However, in the daily routine, our choices are very similar in terms of endpoints. Therefore, although the mechanisms of action might be different, the antidepressants we have at hand in the long term cause similar results. Full remission ratios, let's look at the full remission ratios. In severe depression, our interpretation of the severe depressed patients can be different from the normal population. Although we can see similar results within the general population, we might be able to see different results in subgroups. We have been discussing this since yesterday. There have been oversimplifications through these discussions. Yes, discussing these items is very beneficial because we need new agents. However, this does not mean that what we are discussing today is not valuable. We are clinicians and we have our daily practice to treat our patients. You cannot discuss scientific theories with your patients. You have to perform your daily routine. Therefore, what we do is not any less valuable than the basic sciences which has been promoted in the past days. What can we say? We have a question mark because we do not really know much for the future. There are various areas of discussion in the scientific community. Genetic is one of these areas. There was a recent publication saying genetics do not mean anything. Of course, geneticists answered. They said human genome has been explained, has been illuminated. You are early to give up on genetics, were the words of the geneticists to this publication I have mentioned. But when we go to our offices, we have to treat the patients with the agents at hand. And for the new agents to come into the market, we do not know whether it will happen or not. Therefore, we have to work with what we have at hand in terms of antidepressants. Scientific data we use when discussing, the scientific data we use when discussing and arguing in the scientific community is actually used to say we're not really able to do much. But do you really think that we are not treating depression? We know that we have patients where we are able to deliver a lot. We are not able to do anything is one way of saying it. We're not able to do much is another way of saying it. And we are doing a lot is another way of saying it. So these are all different views. But what do you think? Do you think that we are not able to treat our patients? That's not the case. If we are to use antidepressants throughout life, then I believe our ratios would be much better. Today I do not believe that it's possible to do this, but our ratios would have been higher. The antidepressant groups we have at hand, if they are not really able to perform to the extent that we would like them to perform, then we really need new agents. I'm not saying this for the first stage, but I'm saying this for the second and the third stage of intervention. SSRI and noradrenaline reuptake inhibition, beyond the SSRIs and noradrenaline reuptake inhibitors, we need antidepressants which are more physiologic, which maybe act on dopamine. And I believe that if we have the new agents at hand, I believe we will have much better results. Thank you.